Welcome everyone to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health, reporting for the week of June 24th, 2024. As health professionals rooted in Oakland, serving some of the most vulnerable populations in the Bay Area, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. The goal of the People's Health Briefing is to equip you with the best knowledge and insights to keep you, your loved ones, and your community as safe as possible. This week, after an update on COVID, I'll provide a status update on H5N1 and touch on long COVID and post-COVID in children. First, taking a look at COVID-19 wastewater. Overall activity nationwide is considered low, but you can see it's starting to tick up a bit. And when we take a look at it by region, we can see that the West in particular is climbing, as is the South. And when we look state by state, we can see that levels are very high in New Mexico, Missouri, Florida, Connecticut, Alaska, and Hawaii. And several other states, including California, have high levels. The caveat here is that some of the states have very few sites that are reporting. So if this is something you're interested in, I'd suggest that you find a site near you and keep an eye on that to try to understand what's going on over time. And the link to some resources for that are in the post. And now taking a look at emergency department visits, this is represented as a percentage of all emergency department visits. So this doesn't give us actual numbers, but just a percentage as it relates to all emergency department visits. So this, you would kind of have to assume that all other things are being equal if we wanted to rely on this, which may or may not be the reality. And that's especially the case in respiratory virus season where things are trending up and then coming down. But right now, since flu and RSV season is over, respiratory virus season is over, I do think it's helpful to look at this metric since there are not likely to be other major nationwide conditions that should be impacting emergency departments across the board. So in other words, taking a look at the percentage of emergency department visits due to COVID should give us a bit of an early indicator about where things might be headed. And as we can see here, it looks like we already reached our low point sometime in late April or early, and have been going up ever since then. And one good thing about the emergency department data is it's very current. So we can see that as of June 21st, the proportion of emergency department visits that are due to COVID is increasing. And this follows along with what we are seeing in the wastewater as well. And when we take a look at emergency department visits by age group, it's not a surprise to see that the highest proportion are in the 75 and up age group. And that's followed by the 65 to 74 age group as expected. But what I wanted to point out here is that the next group are the 0 to 11-year-olds. So young children 0 to 11 have the highest percentage of ER visits due to COVID after the 65 and up age group. As you can see here with this yellow dotted line, which is above the red line. The red line represents all ages, and the 0 to 12-year-olds are going to the emergency department with COVID-19 more than all other age groups, with the exception of the 65 and up. So this is something that should concern us all. I'll be talking about kids and COVID a little bit more in a moment. Unfortunately, we no longer have a line of sight on COVID hospitalizations, as hospitals are no longer required to report this information. However, we have seen pretty much predictability season after season that we get increases in wastewater, followed by increases in emergency department visits, then hospitalizations and deaths. So looking at deaths, remember this is lagging. So we have data a month ago. So the week ending May 25th, there were over 300 deaths in the United States from COVID. So this does make about 6 weeks where we have had under 500 deaths in a week. So that is a good thing. Hopefully we'll continue to see that. But based on what we just saw in terms of wastewater and emergency department visits, we would expect the deaths to start going back up in the coming weeks. And of course, we know that we can reduce deaths by ensuring that those who get COVID, who are vulnerable, get treated. Also making sure that folks are staying up to date on their vaccines. And most importantly, making sure that we aren't spreading it to people, especially those who are vulnerable to a poor outcome like death, because we're still having hundreds of people a week die from COVID. So this is still a lot of people, and many of these are preventable. So our goal should continue to be the same: reduce transmission, ensure appropriate access to vaccination and treatment. Now taking a look at variants, KP.3 and LB.1 are continuing to increase, and these each have some unique mutations that help them get around our prior immunity. I reported on that a couple of weeks ago. Also reported at that time that the advisory committee to the FDA recommended that the 2024-25 vaccination should target the JN.1 variant, which we can see is not even really around anymore. But since that time, the FDA has come back and said that based on the most current available data and the rising cases of COVID-19 in many areas across the country, that they are going to determine that the preferred target for the COVID-19 fall vaccine should be the KP.2 strain if it's feasible. Of course, we already saw that the KP.2 is already on the decline, but still the general sense seems to be that choosing any one of these strains, JN.1 or the KPs, will give sufficient coverage. Novavax has already submitted its vaccine candidate for approval, which is going to be against the JN.1, because remember, Novavax, as a more traditional platform, takes longer to update than the mRNA vaccine, so they had to get a head start. It seems that neither Pfizer nor Moderna have yet announced the approach that they're going to take. They haven't submitted their applications for approval yet, but those should be forthcoming. We don't know if they're going to choose the KP.2, but that is what is most likely given the FDA's recommendation. But we will keep an eye out for that and report back when we have more information. So now for a little review of the current situation with H5N1 or avian flu. So we know that H5N1, or so-called bird flu, has been widespread all over the world in wild birds for some time. And we've seen it in other animals and other wildlife. But here recently, it has caused outbreaks in the United States among dairy cows and poultry. And since the first cases were reported in dairy cows just this past spring in the United States, it has spread to 12 states. And since then, there has been spread to at least 3 humans who have gotten H5N1 after what appears to be their exposure to dairy cows, so folks who work with dairy cows. So everything represented here on the slide is basically pretty new in having H5N1 spread from wild birds to poultry to cows and to cats, and then from cows to humans. And we've even seen reports recently of H5N1 being detected in house mice in the state of New Mexico. This is especially concerning because of how close house mice are to people. And most recently, some excellent work in the state of Michigan has given us some insight into the spread of H5N1. Namely, they've demonstrated that it appears that Michigan's first cases actually came in the cows, not in birds, but then it spread from the cows to the chickens. So this is concerning because we know that before it went from birds to cows, but now they're demonstrating that it also went from cows to chickens. And this graphic shows the potential transmission of H5N1 in Michigan. This schematic is supported by sequencing work that they've done in Michigan. So they were actually able to trace the genotypes of the H5N1 and map out the links so they can show you the possible ways in which H5N1 is spreading. So in the top row, we can see that in Michigan, it appears that it started with a herd of cattle that began spreading amongst cattle within the state. Then we start to get into visitors and sharing vehicles and equipment. And then in the third row, this is a pretty concerning row here in that it is hypothesizing that it's actually the workers who work at multiple dairies and multiple flocks, and these workers also have shared housing. And there's some concern that it could be the humans that are actually helping to spread it, and that may have been the cause of spreading from cows to poultry. So all this going back and forth between species is really concerning because that just gives more opportunities for the virus to mutate and adapt. And it's making quite a lot of jumps here lately, especially from birds to mammals and then from cows to humans. And it seems like we are getting closer and closer to a potential danger zone. So definitely want to give credit to the folks in Michigan for doing this detailed work and sharing it transparently with the world. We definitely need to see more of this in order to get a better handle on the situation. But unfortunately, we're seeing that different states are doing different things. It's a little reminiscent of the DIY approach we seem to have taken around COVID, where we had suggestions and recommendations at the federal level, and then weren't necessarily requirements. And so from there, things got decided differently in different places based upon things like politics and the economy, not necessarily based upon public health. And here's already an example as it relates to H5N1, the H5N1 outbreak, where a handful of states are requiring avian flu testing for cows before fairs and exhibits. So this seems perfectly reasonable, seems like a very logical thing to do, at least in the 12 states that have reported H5N1 in their dairy cows. But really, just in general, given the fact that we still don't have a real handle on what's going on, and quite a number of members of the public obviously go to county and state fairs and exhibits and so on. And so even though it's less concerning if you're in a state that hasn't had H5N1 detected yet, we still don't really know when it's going to pop up, where, and it's not completely clear just how much testing is really going on in the first place. At the very least, it would be nice to know how much testing is happening. When they tell us there's only been 3 positive tests so far among humans, I'd like to know how many negatives there have been. And same thing goes for testing animals, testing milk, and so on. This is the kind of transparency I think would be extraordinarily helpful so that we can do better than we've done in the recent past here. And this is a kind of unique situation in that it involves different federal agencies like the USDA. So in addition to the FDA, the CDC, you've got the USDA. And it seems clear that all the details of how these agencies are supposed to work together are not completely delineated, much less mandated or legislated in a situation like this. And of course, each agency has its own things to be concerned about. The USDA regulates meat and poultry and eggs and promotes US agriculture. And the FDA focuses on food and drug safety under Health and Human Services. And even though the CDC obviously monitors communicable diseases among humans, it turns out that there is no federal agency that has the authority to test for human diseases on farms and feedlots. So this seems like an important loophole that needs to be filled like right away. Another concerning thing that has surfaced in all of this is the use of something called chicken litter to feed cows. So apparently, in most large-scale feedlots and farms, they actually feed cows something called chicken litter, which apparently contains dead chickens, chicken excrement, and other scrap. And this clearly represents a risk even before H5N1 in terms of other diseases that cows can get. But especially in light of the H5N1 outbreak, and this practice needs to stop. In fact, it's illegal in Canada and in the UK. And sadly, it appears that legislation must literally be passed in order to end this disturbing practice. Luckily, Senator Cory Booker introduced this legislation called the No Stool in Herd Troughs, abbreviated No SHT Act legislation to end this practice. It's a little bit unbelievable that we actually need legislation in order to discontinue such an unhealthy practice, but this gives a little bit of insight into the strength of the massive American beef market. So in the meantime, avoid raw milk and raw milk products. Don't touch wild birds or any dead animal for that matter. Cook your meats thoroughly. And certainly, if you work closely with animals, please keep an eye on the guidance that is being put out for you. And now I'd like to turn to long COVID and post COVID. First, some highlights from the long COVID household pulse survey, which is ongoing. And just wanted to point out that 6% of all adults in the United States are currently experiencing long COVID. So this is a percentage of all adults. Doesn't matter if you've ever had COVID, ever thought you had COVID or not. This is 6% of all adults. So this is a pretty concerning statistic. And this is currently experiencing long COVID. And out of those currently experiencing long COVID, 80% of them have any activity limitations, 25% have significant activity limitations. And the other thing to note is that out of adults who have ever had long COVID or ever had COVID, 30% have ever experienced long COVID. So this is another pretty concerning statistic here, particularly since there doesn't seem to be any limit to the number of times you can get COVID. And we know that each COVID infection is another opportunity to get long COVID. So this statistic is particularly concerning. Now I want to share a recent article related to children and long COVID. This was published in the Pediatric Infectious Disease Journal last month, May 2024. And I'm sharing this study because it's one of the few that we have that's actually doing objective measurements in children with long COVID. In this study, they did cardiopulmonary exercise testing, or CPET, which is a non-invasive way to evaluate the pulmonary system, the cardiovascular system, and the skeletal muscle system's reaction to exercise in a comprehensive way. There have been some studies looking at CPET among adults, but this one is unique in that it's looking at children. And this is a prospective, case-controlled observational study. So this means we're looking at a control group, so children who did not have long COVID, and then the study group, which is children who do have long COVID, and then comparing the two groups with this comprehensive evaluation. And they looked at a total of 61 children with long COVID and 29 children who did not have long COVID. And these were children aged 12 to 15 years old. And the results were concerning in that over 90% of the long COVID patients had a pathologic test. So they had some impairment compared to only 10% of the healthy controls. So 90% of the long COVID children compared to 10% of those who did not have long COVID had an abnormal cardiopulmonary exercise test. The children with long COVID had a significantly higher probability of having abnormal lung function. They had less efficient heart pumping, and they had some signs of muscle deconditioning. And the article contains quite a lot of detail about what they evaluated and about the findings. So if this is of interest, the link is in the post. Definitely, we need more study. We need more long-term study to see if these things will, let's say, resolve after a year or two, or what will improve and what will not. But this article confirms what we know about post-COVID and that it can continue to affect the lungs and the heart, even in children. So I wanted to take this opportunity to provide a reminder, especially because we're in summer season. A lot of our young people are out there playing sports and being even more active than usual. And I'm finding that many people are still unaware of the recommendations regarding returning to sports and physical activity after a COVID-19 infection. I've reviewed this a couple of times in the past, but I'm going to go over it again. These guidelines have not changed. These are the guidelines of the American Academy of Pediatrics. This is really considered the gold standard around how we should be approaching the health of our children. First off, the American Academy of Pediatrics, or AAP, confirms that any COVID positive individual should isolate at home for at least 5 days and until a minimum of 24 hours have passed with no fever without taking fever-reducing medications. You know, if you have been tuning into the briefing, that we would prefer folks test out of isolation, but nonetheless, the guidance of the AAP is at least 5 days and a minimum of 24 hours without fever, without taking fever-reducing medication. They further say that these individuals should wear a mask when around others for a full 10-day period. And they acknowledge that how severe the initial COVID infection does not predict what's going to happen next. They do acknowledge that we are seeing less myocarditis after COVID than we did in the very early days of the pandemic, which is a good thing. Could be the different strains. It could be, more folks are vaccinated, better population level type of protection. Don't really have all of the details there, but we do know that the incidence of both myocarditis and the multi-system inflammatory condition in children, the incidence of both of those are decreasing. So that is excellent, excellent news. Still, myocarditis is still being reported even after cases of very mild COVID-19. So this is one of the reasons why we want to be very careful and keep an eye on our young ones after they've had a COVID infection, particularly because in those weeks after infection, if they did end up with myocarditis, we don't want them going out to overexert themselves and potentially cause harm. We just also talked about the deconditioning. We talked about the persistent respiratory issues. So definitely want to not push our young people. We don't want to push anyone after being sick, but particularly in this case, want to not assume that children are just going to bounce back and be fine. We want to pay attention to the experts here, and the path is kind of laid out here in this decision tree. So even if the initial COVID infection is very mild, a follow-up visit with the physician is recommended. They do say that this could be a video visit or another electronic method if needed. Athletes and their parents should be given guidance at that time on what to look for, especially as it relates to myocarditis as they return to physical activity. So this means child for any chest pain, any shortness of breath that seems out of proportion, any new palpitations, or certainly fainting. If any of these things happen, the physical activity should be stopped immediately, and you should seek medical care right away for your child. At that point, the child will likely be referred to a pediatric cardiologist. Now, for those with moderate COVID infection, and this means more than 4 days with the fever, more than a week of muscle pains or chills or fatigue. And in this case, the patient should be evaluated by their primary care doctor after the acute infection is over, because this group of patients may be at greater risk for cardiovascular disease. These children should not go back to exercise until they're cleared by their physician. So I'm going to say that again. Moderate infection, so 4 days of having a fever, a week of being fatigued, muscle aches, and so forth. These children should not go back to exercise until they're cleared by their physician. At this point, the physician should review the American Heart Association's 14-element screening evaluation. And the screening evaluation emphasizes cardiac symptoms like the ones I just mentioned: chest pain, shortness of breath, palpitations. They should also get a complete physical exam and an EKG. And if any of that comes out concerning, so any signs, any symptoms, any EKG findings, then there should be a referral to a pediatric cardiologist. The cardiologist might order some further blood tests or further studies, or even send a monitor to go home with. But once again, these children need to be cleared by a physician before they go back to their physical activity. And I'll briefly also note that children and adolescents who have a severe COVID-19 infection, like having to go to the ICU, these children actually need to be restricted from exercise for a minimum of 3 to 6 months. And they must be cleared by a cardiologist before they return to sports. So I hope that that conveys the seriousness with which we should approach the post-COVID period in children. There are real issues that can persist after COVID. There are also post-acute events that can happen, even with children. So we do want to be on alert. The AAP does also go over in detail mitigating transmission among athletes. Transmission among athletes has been documented. It's of greatest concern with indoor sports, especially wrestling, ice hockey, and basketball. They discuss how we should be improving ventilation in indoor settings by opening windows and doors when we can, and by encouraging masking, particularly when COVID-19 levels are high, and or when the athlete or someone on the team household is considered high risk. So the link to all these guidelines is in the post. I'm going to be talking more in the coming weeks about transmission of COVID-19 in our spaces, because there have been a lot of interesting updates in our understanding of how this all works. But I think we know the basics, and we want to mitigate transmission, not just among our athletes or young people, but as much as possible in general. So let's maintain our best practices to avoid getting or spreading COVID-19, stay up to date on vaccination, wear a high quality filtration mask, especially indoors, gather outside whenever you can. And in your indoor spaces, really pay attention to our indoor air quality. And you can assess ventilation with the CO2 monitor. We want to make sure we are well ventilating our spaces and filtering the air when possible. And also we want to be using testing and isolation strategically and as needed. And please don't push yourself. Don't push your child. Allow them the time needed to fully recover. And as I say every briefing, if you don't have a primary care provider, please get one. This goes for your child. I know that after all of the well child exams and the children get a little bit older, perhaps there's a little bit of slacking off on making sure to get the kids in for their annual checkups, but they do need to be evaluated annually. Let them know if your child has had COVID-19, and then also, as I've just reviewed, after an acute infection, they need an appointment just for that, for a post-COVID follow-up. Know how to reach that pediatrician before you need them. And let's establish a relationship with the primary care doctors and know what we need to do for our age and for our risk factors. And remember to eat a balanced diet, incorporate fresh foods, avoid sugary drinks and processed foods, avoid raw milk and raw milk products and undercooked meats. Also, get some regular physical activity unless you don't feel well. In that case, please get your rest, manage your stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.